Hello to everyone and welcome back to my channel. My name is Tommy, I'm a human nutrition student and researcher at the university. What I do in this type of videos is to synthesize the classes and then I explain and teach you the best and most valuable information you need to know. This is the Physiopathology series of videos and today we're going to continue by taking a look at the nervous and hormonal diseases. So let's begin! Starting with the pathophysiology of the hypothalamus and pituitary gland. So we have nerve and hormonal communication signals here. An endocrine gland secretes substances into the bloodstream. An exocrine gland secretes the substances out of the body. But we're going to focus on the endocrine ones. Hypothalamus, it's a source of several neurohormones that act on the pituitary gland. The pituitary gland is a small gland beneath the hypothalamus that divides into two parts. The adenohypophysis or anterior, which secretes various hormones when stimulated by releasing factors or releasing hormones, RH, remember that, from the hypothalamus. And the neurohypophysis or posterior, which is linked to the hypothalamus and releases hormones from the hypothalamus into the blood. So the hormones of the adenohypophysis. General hormones are the prolactin, which is used for the milk production and mammary growth, has no releasing hormone and it is stimulated by sucking at the breast and inhibited by dopamine. Then we have the growth hormone, the GH, which stimulates the growth of all tissues and raises blood sugar. Releasing factor, the GHRH, releasing hormone. Then we also have the gland-specific hormones, the thyrotropin, TSH, which creates the thyroid hormones T3 and T4 in the thyroid. Releasing factor, the TRH. Then we also have the adrenocorticotropin, ACTH, which stimulates the adrenal hormone production. Releasing factor, the corticotropin releasing hormone. Follicle stimulating, the FSH, which creates the spermatozoa in men and the oocytes in women. And the releasing factor is the gonadotropin releasing hormone. The luteinizing, which creates the testosterone in men and the ovulation and progesterone in women. Releasing factor, the gonadotropin releasing hormone. Again, in the neurohypophysis, we have the antidiuretic, the ADH, and the oxytocin. These are created by the hypothalamus. The ADH is used for water reabsorption and it is stimulated by higher osmolarity. And also vasoconstriction, stimulated by the arterial hypotension. This is because it is also called vasopressin. Oxytocin is used for the contraction of the nipple to eject the milk, so the prolactin to create the milk and the oxytocin to release it. And it is stimulated again by sucking. It is also involved in the contraction of the uterus to facilitate the childbirth. All these hormones have negative feedback between the glands and they create the hypothalamic pituitary axis connected by the pituitary portal system. Very important. What are the diseases of the hypothalamic pituitary system? Either by hypofunction or hyperfunction. The most common ones are a GH deficiency, for example, creates pituitary dwarfism. Global pituitary insufficiency, it is called a pan-hypopituitarism. Pan means all. Prolactin producing pituitary tumors. They create galactorrhea, menstrual disorders and low libido. Galactorrhea is the milk production in men, for example. GH producing pituitary tumors create the gigantism and the acromegaly, which is this one. This guy with the face looking like Giga Chad. Now we talk about the pathophysiology of the thyroid. So we have the hypothalamus pituitary thyroid axis. Hypothalamus, the TRH, adenohypophysis, the TSH, and in the thyroid T3 and T4 using iodine. As you can see, it is all connected. The thyroid hormones, 90% of the hormone produced by the thyroid is the T4. And then it is transformed to T3, which is the active one, or transformed to the reverse T3, which is inactive and it is used to save energy. The effects of the thyroid hormones are increased energy, oxygen consumption, thermogenesis, metabolism, fat consumption, protein synthesis, cardiac output, pulmonary ventilation, cognitive capacity and speed of reflexes, sweating tremor, secretion of gastric juices and digestive enzymes. Keep in mind that they increase the metabolism. So now let's take a look at the physiopathological manifestations. So we have the goiter here, which is an enlargement of the thyroid due to thyroiditis, inflammation of the thyroid, which is rare, neoplasms, for example adenomas or carcinomas, and the response to hyperstimulation, the TSH here. When there is low iodine, we increase the TSH. to hyperstimulate the thyroid indeed. Or also by thyroid-stimulating immunoglobulins, the TSI antibodies, in the Graves-Basteux disease. This is the goiter. Hyperthyroidism is the thyroid overfunctioning. With symptoms, it is called thyrotoxicosis. The causes are the Graves-Basteux disease with the TSI antibodies, as you can see, diffuse stimulation affecting the entire gland. It can also be due to a toxic thyroid adenoma, which has an autonomous hormone production. Therefore, if T3 and T4 are created by an exterior source, the TSH will be inhibited and the thyroid will stop working because it has been substituted. Another cause is a toxic multirodular goiter, so a thyroid with many adenomas. The diagnosis is using blood tests, ultrasound and gamma scan. The symptoms: palpitations, tachycardia, weight loss, mydriasis and exophthalmos, the saucer eyes, typical in the Graves-Basteux disease. And then we have the hypothyroidism, which is decreased thyroid hormone synthesis. Causes: autoimmune, such as the Hashimoto's thyroiditis or the thyroid-destroying antibodies, or a removal of the thyroid. The symptoms: low concentration and tiredness, edema and thickened tongue, hoarseness, weight gain and bradycardia. And now it's time to take a look at the adrenal glands physiopathology. So we have the CRH here, the corticotropin releasing hormone, the adrenocorticotropin hormone, and the adrenal hormones, which are in the cortex, the cortisol, aldosterone, and androgen, and in the medulla, the catecholamines. Functions of these hormones are protection against stressful situations, gluconeogenesis, increasing sodium, decrease the potassium, and increase the water retention. And the catecholamines specifically, glucose and fat mobilization for energy. So here I put a little recap to remember everything much faster. Let's take a look at them one by one. Cortisol. In the carbs, they create the gluconeogenesis and insulin sensitivity, hyperglycemia. Proteins, protein catabolism. Lipids, lipolysis and lower lipogenesis. Circulation, hypertension. Ions, sodium retention and they lower the potassium. In the central nervous system, euphoria. And in the immunity is lowered because of anti-inflammatory drugs, for example, they lower the immunity. An excess of cortisol, high corticoids will create Cushing's syndrome. It can be endogenous via ACTH dependent or independent, or exogenous because of drugs. We have to check the ACTH levels, and if they are high, it may be ectopic, so a production not in the place, maybe because of a tumor in the lungs. And if the levels are low, we have to check for adrenal problems, maybe a tumor. And this is the Cushing syndrome, where it is very easy to accumulate fat around the belly and in the face. This is due because of too much corticoids. The diagnosis: we have to measure the cortisol in urine in the morning and in the evening, a radiography and other methods to check the hormones. And we have to treat with drugs or surgery when there is a tumor present. Deficit of cortisol. Types: we have three main types: primary, secondary and tertiary. The primary one is an adrenal insufficiency, so our adrenals don't work properly. And this is the Addison's disease. This is where there is high corticotropin releasing hormone, high ACTH and lower cortisol. The secondary one is in the pituitary, so low CRH, low ACTH and lower cortisol. And the tertiary is the hypothalamic, affecting the CRH. This creates nausea, vomits, hypoglycemia, hypovolemia, hyponatremia, hyperkalemia, and the darkening of the skin, as well as low energy and weight loss. Darkening of the skin not because of the sun. Here I have to say that you have to be careful with the abrupt withdrawal of corticosteroids. Do not stop taking them abruptly, because the pituitary gland and the ACTH are inhibited. If you do so, the treatment is with a lot more corticosteroids, because they are not prepared to start again the process of creating those hormones. So what you need to do is to gradually decrease the consumption of corticosteroids to let the pituitary adapt. Aldosterone, the functions: it increases the sodium reabsorption, it increases the water, the volemia and hypokalemia. And here we have the Cons syndrome, hyperaldosteronism. And 2% of hypertensives have this syndrome. Young hypertensive, possible hyperaldosteronism. And last but not least, here we have the pheochromocytoma, which is high catecholamines. They create hypertension and hyperactivity due to adrenal gland tumor. Now we talk about comas. What is awareness? It is the ability to know oneself and the environment. The content, perceptions, sensations, desires, memory, and reasoning. A state, waking or sleep. Ascending activating reticular system of the renin-angiotensin-aldosterone system. It activates the cerebral cortex via external impulses. Activation of the alpha motor neurons from the cortex to activate the muscles. This is how we function normally. A coma is when you are unable to react to external stimuli, contrary to sleep. Wakefulness, then lethargy, obtundation, stupor, and then coma. These are the stages. And there is a numerical correspondence on the Glasgow scale. The Glasgow parameters are eye-opening, verbal response, and motor response. It goes from 15 to 3. Being lower, it's worse. We have two types here, the neurological coma, in which there are structural lesions, and the metabolic coma, when we have functional alterations. In the neurological one, we have three causes: extensive cortical lesions, for example, repeated heart attacks or encephalopathies. There can also be supratentorial expansive processes or infratentorial injuries. The supratentorial are hemorrhages, abscesses, cysts, tumors, toxoplasmosis, encephalitis, cerebral edema and hypertension, and the infratentorial are brain herniation and various strokes. The causes of the metabolic one are energy production alterations due to hypoxia, hypoglycemia, lower vitamin B1 because it creates the Wernicke encephalopathy, very important, hypothermia or hypothyroidism. Another cause is the hydroelectrolytic alteration, depressant substances, for example alcohol, opiates, neuroleptics, etc. and also endogenous intoxications, uremic, hypercapnic, hepatic, septic, encephalopathies. And now motility. So we require strength and coordination to move. We have two systems here, the pyramidal and the extrapyramidal. The pyramidal system, movement, brainstem, renin-angiotensin-aldosterone system, keeps awake and brain consciousness. We've already seen that in the coma. Two neurons give the signal. The first is a motor neuron, which we call the pyramidal fibers. And the second is a motor neuron that we call peripheral nerve. So the pyramidal fibers and the peripheral nerve. In the extrapyramidal system, these are a cluster of neuronal nuclei and fibers that facilitate the pyramidal system. So they coordinate the movements and they adjust the posture and reflexes. The pyramidal syndrome is when, for example, affecting the pyramidal fibers, so the first motor neuron, we have a loss of strength, hypertonia, so the first neuron has a relaxing effect on the second, hyperreflexia, the second neuron continues to function well. Also the Babinski syndrome, this is when there is a plantar extension response instead of a contracting response. Normally when you touch the feet plantar, it should contract. Instead, in the Babinski syndrome, there is an extension. And no atrophy. Then another pyramidal syndrome is affecting the second neuron, so the peripheral nerve. And it's all the reversed except for the loss of strength. So they coincide in the number 1. Loss of strength, hypotonia, hyporeflexia, no Babinski syndrome, and yes, atrophy. Strength. We say that plasia is the total loss of strength, and paresis is the loss of strength by degrees, and the hemiparesis usually occurs. The lesion may result in monoparesis or monoplasia, paraparesis or paraplegia, and maybe tetraparesis or tetraplegia. In the extrapyramidal syndrome, there is no loss of strength, and this is, for example, the Parkinson's disease, which is a paralysis with shaking, loss of midbrain substantia nigra, neurons, so a dopamine deficiency indeed. The symptoms, to remember them, we say RAT, so rigidity, akinesia, which means slow movements, and tremor. It is treated with dopamine, because it is what is lacking. Taking a look at the stroke, it is poor blood flow to the brain that causes cell death, necrosis. A stroke in one side of the brain affects the functionality of the other side of the body. Very important. It can be ischemic 80% of the times via an obstruction of the vessels by a clot, thrombi, emboli, or stenosis. Or it can be hemorrhagic 20% of the times because of high pressure in the artery, and it creates a rupture and outflow. The ischemic one can be cardioembolic or lacunar. The cardioembolic is auricular fibrillation releasing the thrombi from the right auricle and impacts on the cerebral arteries. And the lacunar one is an obstruction of penetrating arteries and their branches. Middle cerebral artery. So as you can see, these two, they all affect the middle cerebral artery. One by an impact and the other by obstruction. Here we have to say that the facial functions are affected on the same side of the necrosis, whereas the body functions are affected on the other side. This is because the nerves cross after the medulla. Secondary prevention with antiaggregants, anticoagulants and statins, plus rehabilitation. The causes of an hemorrhagic stroke are the hypertension, 180 or 200 millimeters of mercury, the systolic one, plus an extra effort, vascular malformations, amyloid angiopathy, anticoagulant therapy, intratumoral bleeding, cocaine, amphetamine, and also hemorrhagic transformation of ischemic infarction. Here we cannot do the fibrinolysis or the thromboectomy because the problem is different. We have to try to stop the bleeding. What are the risk factors for strokes? Age, hypertension, dyslipidemia, smoking, atrial fibrillation, mechanical valve prostheses, myocardial infarction, microangiopathy, hypertension again, high blood pressure again, and amyloid angiopathy and vascular malformations. In hospitals, there is this thing called the stroke code. It is an emergency and they have to follow a protocol to act as soon as possible. And it is very important to know exactly how much time has passed after a stroke, because if it is too much time and it is not a candidate, no further action will be taken, because it can be even worse for the patient. For example, the fibrinolysis and the pericutaneous thrombectomy, which are used to treat the ischemic stroke, they can be performed within 4.5 hours and 6 hours, respectively. 3 common errors with the stroke. Number 1, never wait to go to the hospital. Number 2, don't take medicines because they can worsen the situation. And number 3, don't think that you are too young to have a stroke. And now, last but not least, endocrinopathies. So a hormone is an organic compound that it is produced in animal bodies to regulate activity and behavior. It can be amino acid derived, peptide and lipid. The hypothalamus controls the anterior pituitary, as we talked about before, which in turn regulates various endocrine glands and organs. Again, we said that in the anterior pituitary, the hormones are produced, and in the posterior, they are simply released. They are produced in the hypothalamus. So the posterior pituitary gland doesn't produce hormones. The physiopathology, for example, when there is resistance to hormone action, the insulin resistance, excessive hormone production, and hyperplasia, tumors, stimulating substances, for example in the Graves-Basedow disease, where there are the TSI antigens that stimulate the thyroid, but also lung cancer with the ACTH. And then alterations of various hormones, in the type 2 diabetes, the pluriglandular syndromes, or for example hyperfunction or hypofunction, that can be autoimmune, and also the abnormal hormone production, in the dwarfism for example. Okay, that's it for this video. I hope you understood everything I said. If you didn't, there is a comment section down below where you can ask me whatever you want. Remember to download this diagram by clicking the first link in the description. Don't forget to like if you enjoyed this video, subscribe to the channel, and share it to your friends and family so they can learn something new today. Thank you so much for watching, and I will see you in the next one. Ciao!